So thanks everybody for being on time after the lunch break, and I am very happy to be here with everybody. So as usual, I'm going to tell you about something else that is super important that needs to be a priority in humanitarian settings. So I don't know if I can ask the slides or, yeah. So it's not a mystery that TB in humanitarian settings is hard, but it just faces a triple neglect. I can give you some figures about how TB remains the number one cause of death as infectious, but it's really something, and I'm not proud of that I've missed cases, I've not referred it on time, I have not taken care of looking for the case of their contact case. It's difficult. When you're in a humanitarian context and everything is a priority, why would you deal with TB? It seems to be so complicated, the protocols are so hard, so it really seems to go in through the cracks of the system. We have built a vertical way of treating TB, and that is not talking to the way children are coming into our settings. So when those systems fail, what do we do as humanitarian actors? Okay, I diagnose and then I refer to the MOH system for the treatment of TB. So in most of our contexts, the more that we do maybe is identify them and then we refer them. That is not a way of dealing with that. In addition, we have this perception of TB as a chronic disease that maybe you missed it, but somebody else will catch it, right? No. TB can present as an acute meningitis. TB can present as so many other clinical ways in children that you're going to miss it. It is extremely hard. I dare everybody here to see the cases that some of your colleagues are seeing. They're not the typical case that is coughing blood, that is having fever. Is not the case. We have cases that almost no sign is exclusive of TB, as some of our colleagues in Afghanistan have seen. And in 2025, we do not have a good diagnostic test. So we're doing some quiz downstairs, and the majority of people are getting wrong some of the questions we're asking, but it's almost impossible to do a clinical diagnosis, a confirmed diagnosis of TB in children. So here we are in a conference about humanitarian pediatrics, and TB covers and touches in almost any aspect of this condition, about the clinical aspect, or the public health aspect, or the aspect about child rights, or the epidemiology, or the elements about training, or the elements about the operational research. Everything can have a link to the gaps that exist today in handling TB. So we're seeing that today almost 60% of the children with TB are underdiagnosed, and this is a real figure. Almost 9 out of 10 children that will die of TB were not put on treatment. And the majority of them are occurring in these unstable settings where the national TB programs are failing. So there are new recommendations. This is not new. This is not MSF. This is WHO came with new recommendations to handle TB in children. There are more than 26. And these new recommendations have the 3 main pillars: more children being diagnosed, shorter treatments, and shorter prevention. And MSF is trying to roll them out with this project. So we're right now working in more than 50 projects, mostly in Africa and Middle East, and we're trying to come with elements of implementation, integration into non-vertical projects, and we're coming also operational research and advocacy components. So what we do is much more than just training. It's actually how do you bring the knowledge into an actual change. So it's standard operating procedures, documents, guidance, referral documents, data collection, the boring part of it, which is actually ensuring that if you have a child, you actually have also the drugs, you order the drugs, you know the drug formulation, and you know which children receive which type of treatment. And also is about the integration. It's also the element of sharing. There's a lot of knowledge. We are in settings that actually are able to do it quite well in some countries. We actually need to allow them to communicate with other projects. And also, we have great tools. At least in MSF, we have access to the telemedicine platform. So we need to be using it to also get access from some specialists that can help you interpret the X-ray or the point-of-care ultrasound or the clinical answers. So we need to use them better. And we're also trying to monitor if our experts, mostly in the global north, are trained into dealing with this condition that they are not so used to. So, and also we're trying to see that this is something that we can do in the more complicated context. So we're not trying to put this in place in the stable project. No, we're trying to do that in Eastern DRC. We're trying to do that in Northern Nigeria. We're trying to do that in South Sudan, because there is actually where we think it has most relevance. And we're trying to come in a way that doesn't need too many more resources. We're not trying here So it needs to be clear. TACTiC project is not trying to solve the problem of TB. We're not coming from the public health approach. We're just trying to see as a child that has TB has the same right to be treated as any other child that comes with malaria or meningitis, pneumonia, or diarrhea. So we're doing these two research on the treatment decision algorithm feasibility and acceptability, which is showing that it works quite well in very busy settings, but there are some challenges in its implementation. And we're also doing a trial on the 4 months regimen in children. 4 months, for those that work in TB, that sounds like great, but for those that work in other settings, that looks like a long treatment. But believe me, 4 months is short when we talk about TB treatment. So we're seeing that actually this 4-month treatment could actually mean much more children to finish their treatment, because a lot of the problems with TB is because it requires so many drugs for such a long time that if you manage to get at least 4 months instead of 6 or 9 or 12, it'll be much easier. So these are children that we need to identify earlier. But what happens? In most of your settings, you find the kid when he's already very, very sick. And being very, very sick is a contraindication for this treatment. So we actually need to find them earlier when we can actually give them the treatment before they don't have access to the shorter treatment. Data. This, what I'm showing you, is data, real data from Niger, of where we're trying to put in place. Obtaining this data from a non-TB project is extremely hard. So this is showing in the orange bars the number of cases admitted in the hospital for any cause, mostly malnourished, or malaria, or dehydration, or shock. So what you could see is our intervention, the blue line. When we come, we give a training, we increase awareness. It works quite well in the low season. But then the peak season comes. And in the peak season, the same people with the same knowledge, they don't perform as well as identifying TB for many reasons. But we see that decrease. Here you could see the structural element. It's not about knowledge. It's not about the procedure. Sometimes it's about the reality of the burden that they see when they're facing, if you could read, more than 1,600 admissions per month. Of course, this is going to be deprioritized. So a meningeal TB becomes a cerebral malaria, because this is what they're seeing. So there's a bias of perception from the clinicians in the heavy settings. And also, we're doing advocacy. One of the pillars is advocacy, what I'm doing here, but we're trying to do it in a programmatic way. This is not about just me telling you, or our team telling you that TB is important. We actually have to come with something concrete. So when we're going to go work with the Ministry of Health, we have to do actually a document that highlights for them what are the key areas that are missing. Okay, now you have TB pediatric recommendations in your guideline, but do you have operating procedures to put them in place at regional level? Have you thought of the stocks that you need of drugs to bring them to the regional level? Have you planned the training for your staff? Have you planned the supplies of the testing? No, that is much harder to do. So that's why we're trying to work with them. We're trying to do workshops and roundtables with the key stakeholders, and it's not MSF that is going to solve that. It has to be a multi-sectorial approach, and let's be honest, the humanitarian sector is not good at talking with other sectors. So again, there are critical lessons that we're getting from this. So the first one is that we cannot let this just be a problem that are dealt only by the people that are working on TB. We need to be, the pediatric community has to own this as one of the issues that we need to solve. The data is the first problem. We do not have data, even ourselves. We don't collect routine data on children that are treated with TB in our non-vertical projects. When we talk about diagnostics, for example, we can put now point-of-care ultrasound, or now there's access to X-rays, but most of our clinicians are still not trained on how to interpret an X-ray. And then the rupture of stocks is a big issue. More than 2,000 patients right now in DRC are waiting for drugs for TB treatment. So this is a disincentive for clinicians to keep looking for it. They know that they're just accumulating there. So why would we look for more children? They don't even have access to the treatment right now. So it's a big cycle that we need to break. And the community engagement, we're not good at that, but they are going to bring us some of the solutions about breaking the stigma and actually being involved in the way we cannot see them as passive in this element. So we're working now with focal points, but the focal points, they're overwhelmed. In MSF and in the Humanitarian, we love the focal point people, but they're actually the ones that are going to be doing the change, and I'm going to be very happy to have Dr. Reza present some of these things. And the element of access to diagnosis. So X-ray is not just a simple tool, it's an extremely useful element. It can tell if a child could avoid a TB treatment. So it is useful that you just don't just do the clinical dose, if you could avoid the treatment if you can. And then the bedside support is essential. So we also need to integrate TB with other comorbidities. So what we think that we're doing with the TB, we could do for other big diseases like sickle cell that are facing similar neglect. And we need to adapt it to the context. So of course, this is not the same in an area with an extremely high burden of TB than in another one. And here I'm involving all of you. So all of you are working with us. I'm not working alone. All our team are working through you. We're working through advisors, to the HR, to the supply, to the pharmacists, the nurses. Everybody's involved in this. But the first element is the ownership from most of your project that this is a priority. And I know that I'm competing with everything. I'm competing with trauma, I'm competing with meningitis, I'm competing with measles, with cholera, but it shouldn't be a competition because you cannot push the problem aside. The problem is still gonna be there. Yes, there's displacement, it's so hard. We ask a mission, can you give us 4 weeks in this project? We say, no, you get 2 days. It's very hard if everything is a priority. When there's an emergency crisis, you reduce to the minimal team, and our team is never in the priority. This is a problem because it means that that remains not a priority. So we need to think that this is essential because it's going to backlash. It's not a matter of child rights. It's a matter that the burden is just going to increase, the mortality is just going to remain high, and the patients are just going to come back. So we need to change that cycle. And finally, it is a problem that we actually bring to the project. They're not coming with us with exceptions. You are going to make this a problem by making it visible. Now you have the data. So we saw it in DRC. This problem that I told you of the 2,000 patients has been there for a long time. But now that we saw that some of these patients are our patients, now it's a little bit more uncomfortable to leave them without treatment. So ownership actually creates action. And it's not a choice, it is a priority. We need to actually engage into an element of change. And again, it seems like public health versus clinical health, but no, you cannot only treat the child. The child you treated for TB, it goes back to the same household or community, and the circle is going to come. It's not going to be treated permanently. Then it's going to be reinfected. So you actually need to treat also the index case. Then that child has siblings. Those siblings should be put on preventive treatment. And that should be still on the clinical part of the TB treatment. It is still not public health. It is just addressing correctly the way you're treating that child. So again, let's not pass the ball. We have to bridge the gap to ensure the continuity of care for these children. But let's be realistic. We are even more isolated, and there's a big funding crisis coming. So there is going to be to make some hard choices in terms of what you do. Let's just remain that this is not something that is a luxury. We need to be able to diagnose these children and put on the treatment. So if you're finding that you are in a project that are not reporting TB cases, maybe you need to call us. Thank you.